tell people all the time that I was on every task force known to man. I jokingly say that because I think Joe Feaster was a prominent attorney, a Black attorney in Boston. He says, there's an army, I don't know, Neil, if it's the Dutch army or one of the armies. He said, you don't get selected because you step forward. You get selected because you didn't step back fast enough. That's me. So I ended up serving on everyone's task force. I was on the governor's COVID-19 task force, COVID-19 working group around the vaccinations. I was on the DPH Health Equity Advisory Group, but Monica Burrell, who's no longer the head commissioner of the Department of Public Health, but a tremendous leader working with the city of Boston on mass CAS and the homeless and substance use disorder issue there. I served on Mayor Walsh, then Mayor Janey's Health Inequities Task Force, which published a report that you'll see here that I'm holding up that had findings for the city of Boston. I served on Mayor Sullivan's task force in the city of Brockton. Everybody, and then not even talking about the private, right? Health centers are rethinking health equity. Hospitals have community advisory boards. I'm serving on BMC's community advisory boards. I'm on Karen Emmons in Harvard School of Public Health. The Chan School has, the Catalyst organization have a community coalition for equity and research to meet the moment around how do we have more diversity and cultural competence in research. And I'm only scratching the surface. Then there's one other national one, a national group that I'm on with governors and mayors across the country looking at modernizing the public health system. Governor Kasich is on that commission. I actually went a little back and forth with him on sports because he doesn't like the Red Sox or the Celtics. So we had a little back and forth on a call recently. It was kind of humbling to be arguing with a former governor. So, but he's on that task force about how we defunded our public health infrastructure over years. And then we didn't allow our public health system to really meet the moment with PPE, with contact tracing, with vaccinations, and we shouldn't have been surprised. All that being said, let's jump in. There's a term called the weathering effect. And Allison, the researchers, when they introduced the weathering effect to me, they said we asked Black parents to rate their kids' asthma from 1 to 10. And I had asthma, my sister had asthma, my mother had asthma. They said we asked Black parents to rate their kids' asthma from 1 to 10. And the parents in that study rated the kids' asthma like 3s, 4s, and 5s. Then the doctors came in, the researchers, looked at those same children and they were 8s, 9s, and 10s in terms of severity of asthma. And they said, Michael, this is the weathering effect, that you can get so weathered to taking the Flovin and the Alupin every day. You can get so weathered to sitting in the emergency room once a month or once a quarter. You can get so weathered to sitting out of gym in school that you become weathered to being sick. I want you to let that sit in for a minute. You become weathered to being sick. So it becomes normal to you. So let's talk about disease across all the different types of diseases and whether communities and society's been weathered to higher rates of asthma and prostate cancer and colorectal cancer and infant mortality. And I mean, the list goes, lupus goes down the list where Black and brown folks live shorter lives, die of almost every disease. But I want to make it a broader conversation, Elizabeth, about weathering. What are you weathered to as students, as professors? The morbidity and mortality, the life expectancy, which we'll talk about in a second, the disparate treatment that the Institute of Medicine put out in 2002, that actually was a revelation for many, right? Many community activists have been saying, doctors don't treat us the same. They think we Black folks have higher thresholds for pain, that we're just trying to get drugs because we're drug addicts, or that we don't get, we get amputated where other people get courses of treatment that save their limbs, and so many other manifestations that activists and patient advocates have been saying for years, that now the Institute of Medicine put in a report called Unequal Treatment, validating those activists. Incarceration rates, we now know after Michelle Alexander's The New Jim Crow and many other books, Elizabeth Hinton's book, from the war on crime, the war on poverty, we now know that there was mass incarceration. We pipelined Black and brown citizens into prison. And they didn't get adequate health care, and they came home broken and came home from, as I call it, gladiator school, without a job and unable to get employment. And what does that mean for our healthcare system? Food insecurity, housing insecurity. Are you weathered to that? K through 12 education inequity and disparate discipline. We now know about suspension and expulsions and medication of children and how the inequities play out there, college and higher ed. Those achievement gaps exist there as well, and disparate discipline there as well, over-policing in communities, right? We just watched the Kyle Rittenhouse case, right? And we talked about the disparities and the differences about whether people can arm themselves and walk out in the streets and murder people, whether it's self-defense or not, and be able to get away with it. And there's a disparity in our criminal justice system. We now have a reckoning on that lack of political power and influence. We talk about redistricting, and the first elected mayor of color since 1822 in the city of Boston is now an Asian woman. Why did it take us so long to realize that talentless exists in all of us? And that Sherry might have had a different perspective on how to solve development or build development in Boston. And Allison might have had a different perspective on how to do substance use disorder in communities across the city. But yet we didn't tap all that rich talent, discipline and employment, lack of diversity in our medical schools. The pipeline is not diverse. We relegated the pipeline, the distribution and the production of Black and Latinx clinical leaders to Howard University and to the University of Puerto Rico and to historically Black and Latinx institution to produce our next doctors, because a majority of them are coming through those pipelines and not through our traditional academic medical centers, our academic centers. Environmental injustice, climate change, anti-immigrant policies, microaggressions, racism in the media and entertainment, employment discrimination, high rates of uninsurance and underinsurance, predatory practices, not just lending, wealth and wage inequality. It's just a scratch of the surface. This is what kept me up at night when I was president of NAACP and leading the health center movement. This is what people don't see. And this is only a partial list. But I asked the question, what are you weathered to? Do you see it? I use the analogy of the little kid in the movie Sixth Sense. I know some folks on this call are a little young, so they might not remember the little boy. The classic line from that movie is, "I see dead people." I saw Allison quoting it when I said that. Here's the reality is, I use that analogy because the little boy didn't want to see it, because seeing it meant that you'd be crazy. Seeing it meant that you might not get invited to the meeting. People would think that something was wrong with you. Seeing it meant you had to do something about it. So I've argued for years when it comes to health inequity and injustice in our healthcare system, we didn't want to see it because seeing it meant we had to do something about it, and it came with risk. So let's acclimate ourselves really quickly to where we are, because I think that's important. And I don't want to gloss over weathering, because weathering is also about the hospitalization, infection, and death rates from COVID-19. 262 million cases worldwide as of yesterday. 5.2 million deaths. Lost lives, empty chairs, lost family members. 3.2 billion persons fully vaccinated. And quite frankly, we're seeing inequities playing out across the globe. I'll talk about in a second. Over 48.3 million cases in the US with close to 779,000 deaths. We've surpassed the amount that most estimate from the Spanish flu in 1918. Over 197.1 million fully vaccinated, with over 41.1 million with booster doses. Close to 856,000 cases in Massachusetts, with just under 19,000 confirmed deaths, with close to 4.9 fully vaccinated. So let's talk a little bit about issues. Inadequate public health infrastructure. Like I mentioned earlier, we defund. We use this defunding term all the time. I actually kind of tease people. We talk about defunding police. We defund stuff all the time. We don't like to use that term, but we defunded our pandemic response between administrations, presidential administrations. We defund public health all the time. We defund oral health. We defund Medicare and mass health, and the Massachusetts Mass Health is Medicaid program. We defund things all the time. That's what policy is. People make really critical decisions about where to move money to and from, and we defund things all the time. We make really critical decisions. Sometimes they make sense, and sometimes they don't. And as an advocate, a public health person, a health center advocate, a civil rights advocate, I'm often challenging people to fund things appropriately or to not defund them. So let's talk about the variant, Omicron variant. November 24th reported to World Health Organization, we should be afraid of variants. They are here, likely to be coming for years to come. And particularly, I want to warn people, they will come as long as we don't have vaccinated people. And I'm not necessarily worried about Neil. I'm worried about Tanya in India, or Jack in Africa, or name the country where they haven't even gotten their first shot, and we're talking about boosters. And that's where this variant has life, where it can mutate, where the variants will likely come from is, as we see in this country, an uptake, and though we are not where we need to be in terms of a critical mass of folks taking the vaccine, there are some countries, particularly those that are Black and brown, that haven't even gotten one shot yet. Access to timely and reliable information, poor surveillance and sequencing. We need to know where this disease is, what the variants are. We've not done that well. And one interesting note, Neil, that I like to always point out, the Spanish flu, as many people know, that history is called the Spanish flu because Spain recognized that they had a problem. When in fact, the world had a problem in 1918, going into the fall of 1918. That deadly influenza pandemic that was taking over the globe during a world war, where the past is prologue. I got to dig in a little bit of my Shakespeare when I say that. The past is prologue because we're going through that now. People want to deny the importance of masks. They did that in 1918. They wanted to downplay the disease. They did that in 1918, going through 1919. They wanted to maybe not even acknowledge that there was a disease, a problem, because then it would be their disease. The China flu, the Spanish flu, the South African variant, right? People are now in this public health challenge of, do I bring my information, or does that now create a perception of our country, right? None of this is new, by the way. This is the work that you do in this course, is understanding that none of this is new. This is all recycled. You know, this is the past is prologue. Disparate impact that the disease has had. Congresswoman Ayanna Pressley, the congresswoman in one of the congresswomen in Massachusetts, dynamic sister, she always says those closest to the pain should be closest to the power. I've been spinning her quote all over the place, right? Closest to the pain should be close to the vaccine. Close to the pain should be close to the table for the solution, right? The disparate impact that this has had on the populations closest to the pain, and then the under-vaccinated countries, India, Africa, Indonesia, Iraq, Ethiopia, Afghanistan. The list is long, but you should look that up yourself and see the disparities that are playing out with access to this vaccination. And then, of course, the red spots, right? The vaccination uptake. The WHO website can give you a sense for where the countries are in terms of the distribution of vaccines. And again, we're looking at boosters. We're talking about kids, we're talking about boosters, when some countries haven't even gotten their first shot, in Africa being a great example of the inequity that exists across the globe. So general equity issues, timely racial ethnic data, adequate testing, contact tracing, treatment. We're talking about monoclonal antibodies, or remdesivir, and now Manuprevir, I can never say the name, Manuprevir, with alternatives for isolation and quarantining. I'm in those conversations with DPH. We probably have a call every 2 weeks about a therapeutic, a treatment for COVID-19, and the fact that equity has to be centered. And of course, I'm the canary in the coal mine, beating that drum around equity, because monoclonal antibodies, most Black and brown folks here in across the country, other than Donald Trump receiving a treatment, probably never had that offered to them. They don't even know what it is, because many of the people who had access to it are not in the communities where our health centers are located. Because of the infusion therapy systems that are needed, they tend to be in hospitals. So by the time you have the offer to do that, you are hospitalized, or you at some stage, and unfortunately that's not reaching folks in many of the communities that health centers serve. So these pills could be, if they're proven to be efficacious and safe, could be game changers for people who have low levels of the disease, and we can deploy the pills to keep it from becoming severe or preventing death. So but there's always equity issues, right? You don't want another Tuskegee syphilis. So do we give you a drug that is in emergency use status or in the fringe of emergency use, but we don't know all the data yet? But do we push that into communities of color because they haven't had access to monoclonal antibodies and remdesivir and other courses of treatment? Or do you wait until there's more data and more science? That's all the complications that go on a regular basis in this work here at the Mass League, working with DPH and healthcare leaders across the state. Protection for healthcare workers, PPE, timely and reliable information. We're not getting it. How do you get it? Where do you get it from? Who do you trust? Access to resources, mortgage, rent relief, food supplies. I'm covering this quickly because this is all just sort of peripheral to the issues I really want to get to. Digital divide. It took a pandemic to force us to do telehealth. Just so folks know, this policy doesn't work. I said this earlier to the host for today, the professors. I said it's interesting about policy because we can know we need to do something in our legislatures, in our city governments, and federally, and we still won't do it. We won't do it because it costs too much. We won't do it because folks think it won't be as effective, or it'll impact a certain industry, and it may have some impact on the finances of some entity that has a power and influence in our city halls or in state legislatures or down in DC. So we don't do it. Digital divide is one. We already knew we should have adopted telehealth. We've been advocating for years, but it took a pandemic to make us realize we could work remotely, teach remotely, provide care remotely, but we still have to solve for the divide that meant that many communities don't have the Wi-Fi access, the broadband access to get access to this technology. This chilling effect of all this anti-immigrant policy, pre and post President Trump, that existed, that really drove people in the shadows. And it is not in any of our best interests. If you are Haitian, if you are Honduran, if you are Mexican, if you are, no matter what country you are from, if you're in this country and you're not seeking care, if you're in this country and you're not coming forward when you need to get contact traced or treated for your COVID-19, it has impacts on all of us. And unfortunately, because of policies, we've driven people in the shadows where they can't come out of the shadows out of fear of the policies that we have in this country. Then diversity in vaccine clinical trials. Of course, we've come reckoning an epiphany that our trials were not diverse. I won't cover this because you've covered it in class, but the racial disparities that played out with deaths, with hospitalizations, with vaccinations. And I was on the front lines with Governor Baker, and Mayor Walsh, now then Mayor Janey, and now Mayor Wu, around how do we get vaccines out equitably, and that's partnerships, right? We learned that that churches can partner with hospitals, can partner with health centers, can partner with activists, and create access points for care. Now, again, just like technology, we should have known that partnerships matter and they're effective, but we didn't do it. Right? We were starting in our very healthcare tribal ways. And it took a pandemic to force us to come together to do this in a way that got more vaccines in the arms in a rapid way. And quite frankly, we are, and though I would say we're the best of the worst, right, Neil? I don't think that we've done it excellently, but we've done it better than many other states in terms of making sure we did it equitably. That was because of people beating the drum around partnerships, around investment, and around empowering communities to have a seat at the table, being part of that. Maybe one little, another quick point I'll make is the health center movement. I'm a civil rights dude, right? My compass is adjusted not by my gut, but by reading Souls of Black folks, by knowing intimately the policies and the data behind the new Jim Crow, by knowing who Jack Geiger and Count Gibson were, who created the health center movement. I don't have the gut isn't guiding me. I'm guided by research and analysis and history that helps me make the decisions I make along the way. So I'm grounded in equity. Health centers were born out of this health center movement. 1965, the Nation First Community Health Centers were launched as a part of a small demonstration program, part of the President Johnson's Office of Economic Opportunity, the War on Poverty, with roots in both the civil rights movement and the war on poverty. As I said, the earliest health centers had as their mission, no less than using the healthcare system to change the health and lives of their community's residents. Community health centers were created, as I said, out of the American Civil Rights Movement in the 1960s by civil rights activists who were civil rights workers. The vision of health centers and the first health centers born out of South Africa. Thus, community health centers and civil rights are connected to a common history, and those names, commit them to your memory, because these are names in this space that you got to know. If you're in Massachusetts, in Boston, in healthcare and primary care, you need to know who Dr. H. Jack Geiger is, who Dr. Count Gibson is from Tufts University Medical School. You need to know who Dr. John Hatch is, and Dr. L.C. Dorsey, and Dr. Andrew James, and Dr. Smith, Black doctors who organized along with white doctors to really take up the caboose of the civil rights movement, which was healthcare. It's great to integrate lunch counters. It's great to integrate schools, but people were dying then and now, living shorter lives, dying unnecessarily. So they understood that. And just as a marker, Neil, because we're in this moment, I tell people they were masterful. It was never just about healthcare. It was never just about your eyes, your teeth, your mental health, your physical health. It was also about the water you drink. Flint, Michigan. It was also about making sure you had access to food and that you had a seat at the table on the board, so that health centers had 50% of their board members have to be consumers of the care at the health center. That's way before its time. We're talking about the 1960s, 1970s. Health centers just writ large, just to get a sense, 52 across the state, serving over 1 million patients out of 300 plus practice sites, serving 96% of the state's zip codes, right? So even if you don't have a health center, you don't have a hospital, most likely. You don't have a community hospital, you're driving to a health center to get your care. You see some of the gaps on this map. 1 in 7 in Massachusetts get their care at a health center, 1 in 2 in the city of Boston. So, the league, which is where I sit right now, the role that we have is workforce development, analysis, information technology development, clinical quality initiatives. My staff here is focused on training and education. How do we build the next workforce? How do we make sure our clinical staff, down from our doctors and nurses to our community health workers, have what they need to be effective? And then supporting to expand health access. We're advocates, we're leaders. If there's a table, Neil, they say if you're not at the table, you're on the table or you're on the menu. So our responsibility is to be at the table so that we don't, and our patients don't, our health centers don't end up on the menu. And then information dissemination. Some quick stuff for reference. Over almost 840,000 patients receive medical care, dental care, behavioral health. You'll see the numbers there. I won't cover them all. And then patients receive vision care. It is way before we got to this notion of patient-centered medical home, there was a health center. So you can walk down the hall and get your eyes taken care of. You can turn the corner in the building and go get an appointment for your mental health. You can get that pain in your side dealt with by your primary care. All in one place, all in one set. That was, when I tell you, I think that they were like brilliant in 1960s to create this model. And even then, it's not perfect. Even then, we're still trying to refine and think about what our responsibility is. So 66% of the Massachusetts patients identify as racial ethnic minority. 61.8% of our patients are best served in a language other than English. Those closest to the pain, those historically marginalized, incarcerated, underserved communities, discriminated against, excluded, experimented on. Those are the people we serve, both here and across the country. Those are our patients, whether they're Honduran, Haitian, speaking Creole, or Russian in Springfield, right? We are providing care across the Commonwealth to those patients. And 79.5% of health center patients are low income. You'll see the distribution there, almost 43% of Medicaid, 28% private. And that looks different depending on what health center. If you're at Fenway Community Health Center, a health center is groundbreaking around LGBTQ issues and HIV/AIDS, that's more commercial. But if you're at Lynn Community Health Center, it is heavily Medicaid and heavily still uninsured. Even though we have the highest uninsured rate in the state, health centers still see the remaining uninsured. And just in case you didn't know, if you don't know now, a large percentage of them are undocumented. So they come to get their care at a health center. Now, here's why I show you all of that, because I want to get into a little depth here and I want to try to move more quickly. Here's some data that I thought was fascinating, and I just presented this recently at Harvard Medical School. Our patient distribution by age. Now, I grew up in health centers, right? I was raised in a health center from that, like maybe 3 to 17-year-old age. So I'm in that second part of the graph, the chart, where you'll see 1 to 17. Then we see this huge spike of 18 to 64-year-old. But then I had to ask the question, what happens to our patients when they become 65 plus? And then I remembered, as I was talking about this, that I sat with the governor's working group on COVID-19 and vaccine distribution. And one of the conversations way before you got a vaccine, everybody on the call, was we were in the room trying to figure out what the prioritization would be for the vaccine distribution. And I was there with Liz Walker, who's a prominent reverend, and Wanda McLean, who was in the MGBI, BWI system at the time, African Americans. And we said, we got to make sure that the vaccine gets to those closest to the pain, the Roxbury's, the Chelseas, the Lynn's, the Lawrences, because the rates of infection, the hospitalization, and the deaths are high. And there was a push to do 75 plus as the vaccine first distribution. And then as they ran the data with all the smart physicians and epidemiologists and scientists in the room, they said, well, actually, that won't deal with the equity issues. So you had folks like myself who said, nah, that won't work. That we can't distribute these vaccines in a way that won't reach the communities where I grew up that are having a disparate impact from this disease. We got to make sure either we move quickly from 75 plus because we know they're more vulnerable, but they're also more white. How do we get to those 50, 60-year-olds who are Black and brown who are also dying at a younger age of COVID-19? That was the debate. This is the real critical work that you're going to have to do when you're out of school. Is you're going to have to be in rooms where you have to ask critical questions. You have to understand the data. You have to be the canary in the coal mine, because it's not just about you. It's about those patients that don't have a seat at the table. And you can't go from your gut. You have to go from the science. You have to know that you've been taught and trained and aware of what equity looks like. And equity is always competing with something else. Always. So let's just talk really quickly about these patients. So 75 patients, 75 to 85, the percent of total health center population, only 3%. Percent of the overall Massachusetts population, 6.7%. 85 plus, less than 1% of our patient population, 1.8% of the overall state population. Massachusetts, generally a wealthy and educated state with one of the highest rates of health coverage and access to healthcare, has the 6th highest life expectancy in the country, 80.7 years, compared to the national average of 78.7 years. All of the 72 Massachusetts census tracts with an average life expectancy of 75 years and under, between 68.1 and 75, represent under-resourced communities served by health centers. We are in those neighborhoods where people are living shorter lifespans. New Bedford, 68.1 years, 12.6 years below the state average and 10.6 years below the national average. Fall River, Springfield, lowest life expectancies between 70 and 74 years. We're in the Metro Center, Bay and Pine Point neighborhoods. This is just all fascinating stuff where you dig into the data, census tracts and life expectancy and health center populations by age. New Bedford, and this gets a little bit more into the detail. New Bedford, Black, 5.1% by race and ethnicity. American Indian, Asian, white, Hispanic, median income. Fall River, New Bedford. So I won't spend a lot of time here. This is just new data that we've still combing through, but it's been, confirming, for lack of a better word, in the last few weeks. Hyannis, Brockton, Pittsfield, Worcester, Franklin, right? We talk about life expectancy. Let's talk about who's in those communities. Higher rates of cancer and hypertension and heart disease and, all these diseases, right? And asthma and trauma. Roxbury, Haverhill, Lowell, Dorchester, Webster. Again, income, right? We talk about social determinants of health, Neil. We've only scratched the surface to understand that 75, 80% plus of your health status being impacted by conditions you live in, circumstances you live in, not necessarily by the care you get. So now we are having this awakening about racism, about poor infrastructure and rat and roach infected houses and all these other key issues. And unfortunately, from a healthcare perspective, what we've been doing is bandaging your boo-boo, treating your cancer, and sending you back to the same conditions. There lies the rub. Holyoke, Lynn, Taunton, Fitchburg, life expectancy, median income. So 22% of Massachusetts health center patients and children, as we, of course, were on the front lines of also trying to figure out how to vaccinate more kids, particularly kids of color. 24% of children under 11 identify as Black or African-American, with 40% identified as Hispanic or Latinx. Health centers are collaborating with local schools. We're doing this vaccinations in school. My son got his vaccination at his middle school. And other community-based organizations set up to set up vaccine clinics, providing vaccine within the context of well-child. We need to make this normalized. You come in for a visit, you get your COVID shot. Just like you come in for a visit, you get your flu shot. That is our reality going forward, that COVID shots will become as normalized, or should become as normalized as any other course of treatment that we provide. Monoclonal antibodies, I mentioned that earlier. This is the cutting edge stuff that we need to be aware of. I remember, Neil, when this time last year, when monoclonal antibodies were becoming available and the Trump administration was trying to push it out, I was sitting in a call with DPH. They were like, well, we don't really even know if it works, but we're being told to give it out. We don't even know if it's safe, but we're really being told to give it out. So we probably want to be cautious about what we do. And I think it's borne out to be actually pretty safe, maybe, right? I think the data, at least I've seen, Neil, is that it's been safe and it's been helpful in saving lives, but it just shows that we're in a exigent circumstances, that we're trying to build a plane as we fly it, and then we're trying to deal with the equity implications as we build it. And that's all challenging, and sometimes equity takes a backseat. Monoclonal antibodies, and then of course, oral antivirals be a game changer for COVID-19, and what are the equity concerns there? And then something that I'm not sure everyone on this call has been aware of, these are recent reports that I just want to point you to as we start talking about, what we're seeing here and across the country. The top line of this is states have large racial disparities in healthcare equity study finds. And then the top line of that is, we don't really see health equity anywhere in the country, says the lead author of the new study from the Commonwealth Fund. Anywhere in the country. I used the phrase earlier that Massachusetts is the best of the worst. We love to tout how we're better than Alabama, as if that's a good thing, right? Commonwealth Fund President David Blumenthal said people of color are having vastly different experiences than white residents within the same health system, which has led to a range of deep-seated inequities. He went on to say that health disparities have only been exacerbated by the COVID-19 pandemic, which has disproportionately impacted people of color, Latino, Black, American Indian, Alaskan Native people are at least twice as likely as white people to die from COVID-19, with the American Indian and Alaskan Native residents more than 3 times as likely to be hospitalized from the disease. And you'll see there the bottom article, also recent, echoes of the past. Study points to redlining. If you don't know what redlining is, you should, as a factor in premature birth and maternal health. So revelations, right? These epiphanies. I use often, Neil, this statement I often say on, and Emily, on my Facebook page. I said, I'm glad so many people are woke and others are waking up, but some of us are insomniacs. So I'm asking you to be insomniacs about health equity. Don't go to sleep. You need to see it, be aware of it, be vigilant, be prepared to address it in whatever setting you decide to work in and practice in later. One other thing, and I'll say this, Carter G. Woodson, the founder of Negro History Week, now Black History Month, he said, history was not the mere gathering of facts, wasn't just the mere gathering of facts. The object of historical study is to arrive at a reasonable interpretation of the facts. That's Carter G. Woodson, Black History Month. Dr. King said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Medical Committee for Human Rights in Chicago, March 1966. Rebecca Lee Crumpler, I mentioned her earlier. They seem to forget there's a cause for every ailment, and then it may be in their power to remove it. 1864, I always say that was a bad sister. She was a doctor of medicine in 1864, right? If we were talking about 1920, we'd be talking about an amazing person. We're talking about 1864, during Reconstruction, the end of slavery, the emancipation of slaves. She was leading a movement around trying to get care to these former slaves. Only female physician author of the 19th century, published a book on medical discourses, studied at New England Female Medical College, began her career practicing medicine in Boston, treating women and children, worked for the Freedmen's Bureau, which you need to know about, providing medical care to former slaves. And her house is on Joy Street, a destination on the Freedom Trail. You need to know who Annika, Lucy, and Betsy are. I know you probably talked about it in class, but I want to say their names. right? I always tell we tell Ahmaud Arbery, Michael Brown, Tamir Rice. I want to say their names: Annika, Lucy, and Betsy. Right? These were the victims of the father of modern surgical gynecology. Right? Somebody we still lift up and revere today for his groundbreaking techniques, the tools and surgical techniques related to women's reproductive health. This is our healthcare system. Well, so I always say, Neil, as we start to rethink about our system, not just healthcare, but our health system, not just the care. We're talking about insurance. We're talking about durable medical. We're talking about research. We're talking about all of it. Let's start with being true about what it is and what it was. So he invented the vaginal speculum, a tool used for dilation and examination, practicing at a time when treating women, white women, was considered distasteful and rarely done. He pioneered a surgical technique to repair vesicovaginal fistula, a common 19th century complication of childbirth in which a tear between the uterus and bladder caused constant pain and urine leakage, and lionized in New York and South Carolina, Pennsylvania. They were tearing down his statues and removing it over the last few years. That one on the bottom is Central Park. We know the Tuskegee syphilis, that's the awareness that we've had around those Black men who are part of that unethical treatment. One of the things that made the experimentation under J. Marion Sims unethical was that not only were they slaves, so there was no consent, but also it was done without anesthesia. So we talk about the unethicalness, using that phrase, the unethical nature of the Tuskegee experiment. This was the science. We Black people had bad blood. We were the, quote, syphilis-soaked race. So let's have a reckoning about why folks won't take a vaccine today, or why they won't come in to be part of a clinical trial. And even if you are on this call and you're African-American and you're 20, maybe, you ain't never heard of any of this, I would say to you, it didn't matter if you heard it, because your mother told you, don't go down to that hospital because they go there to die. Don't go to that clinic because they don't treat us the same. Don't get in that clinical trial because they just experimented on you, baby. Don't do that. So this history gets passed down, whether you know the specifics of it or not. Henrietta Lacks, you know that story. Racial justice has been elusive in part because African Americans have been unable to tell our stories or control the construction and distribution of our own narratives. I would stretch that and to do the research and analysis and provide findings on the conditions in which we live. Many times people didn't do the research on the issues and conditions in which we live, because if they did, they'd have to do something about it and they'd have to tell the truth. One of the best ways to not tell the truth is not to reveal, right? So that's the fascinating part about this work. Of course, we know that medicine's had a reckoning for over 100 years. State and local medical societies openly discriminated against Black physicians, barring them from membership, from professional support advancement. The American Medical Association was early and persistent in countenancing this racial segregation. In 2008, after a 3-year study on the racial divide in organized medicine concluded, the AMA publicly apologized for its past discriminatory practices against Black physicians. Several key historical episodes demonstrate that many of the decisions and practices that established and maintained medical professional segregation were challenged by Black and white physicians, both within and outside of organized medicine. So I tend to reframe Medicare and Medicaid as civil rights bills because they integrated our hospital systems. They forced hospitals to open up. This was a historical minute ago that my mother couldn't have gotten care in some of the same hospitals that provided care to white families. So we're not talking about ancient history if you're on this call. We're talking about, and I want you to coin this phrase, a historical minute ago. So doctors, where do they come from? Who's training them? Who's preparing them? What is the pipeline? Now, I always say this, Neil, and for the rest of the professors on the call, for anybody who's ever heard of or met Kazmia Corbett, I was in a club, really a bar, so I'm revealing my truth. I went out to a bar in Boston called Slaves, where if you're African-American, you've been there. And if you're other, you've been there. But it used to be Bill Russell's club that he created when he was at the Celtics. And I was there one night. The pandemic has sort of opened up a little bit. People were back out, masked or distanced. And somebody tapped me on the shoulder and said, hey, I want to introduce you to somebody I'm with tonight. And I turned around and I said, this is Kazmia Corbett. And you would think I met Michael Jordan. I turned around, I was like, of course I know who you are. You were the young Black woman on the team that found the Moderna vaccine. And I talk about you all the time. And here's what I said to her. I said, I make the point about diversity, equity, inclusion. There's a little Black girl sitting in Chicago right now, or Roxbury, or North Minneapolis, that's meant to find a cure for cancer, but we will never know her. We will never know her because she doesn't have the academic rigor, she doesn't have the social support, because she's internalized racism, doesn't think Black people can be doctors, or the Latinx girl, or the Asian boy. That's how pervasive and how corrosive racism is. We don't have all that talent boil up, and it impacts all of us, which is why this issue of a pipeline of diverse providers, of clinicians, of professionals is important. And it's not just about making you feel good that you got more diversity sitting in your class. It was never about that. Where are they graduating from? You know, where are these Black and brown professionals coming from in our healthcare sector? Who's investing in their development and their success and in their now everybody's having an epiphany and a reckoning, right? So Harvard University, I was on with Harvard Medical School. I'm often on with the Chan School. I'm talking to medical schools across the country. Everybody's trying to figure this out now, but here's the reality. The reality is there was always talent in those little girls. There was always talent in those little Black and brown girls. It was about opportunity. It's about the social determinants of success, right? About how we invested in people to be successful. Last but not least, and I want to just cover these slides really quickly. Color of wealth in Boston, money matters. Boston Federal Reserve Bank put out a report a few years ago. It's been rippling across the country. The net worth of an African-American in Boston is $8 compared to $247,000 for white Bostonians. What does that mean when you are living in debt? You're living without wealth. You're not able to leave anything to your kids. You're not even probably able to bury your families when they pass. Right now, there's been some tinkering with these numbers, but the reality is it doesn't matter. The disparities exist. So last but not least, and then I'll kind of close it out, is social determinants of health. And I'm trying to do a time check, but I have no idea where I put my phone. Social determinants of health. Health centers are being challenged right now. Neil, how much time do we have?
You're good. You've got about 7 minutes. We're hoping to maybe have a few minutes for questions at the end.
Good, perfect. So I'm going to start to wrap it up. I'm going to talk real quick. So one is health centers. Even though we were born out of civil rights, you know, we sort of raised that banner and beat our chest because we come out of that movement. The reality is, if you walked into many health centers across this country, they're led by white folks. There's not enough diversity in the C-suites. There may not be many Black doctors or nurses now. We have more than most, by the way. So we do have something to be proud of. But again, it's the best of the worst. How are we creating pipelines? Now we have loan repayment. We're doing the workforce stuff to create these pipelines, but we did not even lean in the ways we should. So we're having this reckoning even within our movements. We are loved and liked, maybe not always loved, but liked by Democrats and Republicans. So are we leaning on a criminal justice reform, the George Floyd Justice and Policing Bill? Are we leaning in on the collection of race and ethnicity data so that we can now understand who's being impacted by disease in a way that we can respond? Are we leaning in on policy issues like economic disparities, loss of wealth, credit scores, unemployment, the things that are driving people in our health centers sick? Are we leaning in on those things? They're all in these reports. That's what these reports are about. They're all pointing out that we always tinker around the edges, but we don't do the real systemic work. That's why I sat on BMC's Racial Justice Initiative that Kate Walsh announced. She's the head of Boston Medical Center. They're now taking race. And what they're doing, Neil, is they're actually having an honest look at themselves around the disparities around maternal health, around access to services, and they're revealing what they're finding. That's transformational because nobody wants to tell the truth. So you now have a meeting I have with the new head of Boston Brigham and Women's Hospital, African-American man. They're looking internally at the disparities in the care that they provide. And then what is their role to lean in on issues outside of Brigham's and Women's or the Mass General Brigham's system generally. This is where we are now. I ask the question all the time, is this a moment or a movement? I don't even know the answer to that. But I do know I like what I see. I like the fact that people are thinking about it, that having honest conversations. Now, here's a great, and you're all getting breaking news, Elizabeth, so I'm about to tell you something that not a lot of people know. It's not even been in the media yet. Right now, there are more Black and Latinx leaders in healthcare than I've ever seen. Ever seen. Juan LaPera, Latinx brother who's the head of diversity, equity, and inclusion for B.I. Leahy. Jeffrey Sanchez, former state rep, led most of the public health disparities bills. Maisha Minter-Jordan at CareQuest on the oral health space. The new head of Point 32, the merger between Tufts Health Plan and Harvard, is Kane Hayes. The new head of the Boston Foundation, Kevin Churchwood, Children's Hospital, Christopher Lathan, Charles Anderson, David Williams at Harvard School of Public Health. There is a major movement around diversity in healthcare right now in health. Manny Lopes just went over to Blue Cross reporting to Andrew Dreyfus, Kizzmekia Corbett, right? Right now, we're pulling this whole group together to figure out what we can do to make sure we don't miss the moment. So I've convened them along with Juan LaPera and Jeffrey Sanchez, call this group together and say, let's talk about a plan. What are we individually doing to deal with health inequity? What can we do together? Joan Reed at the medical school, the Harvard Medical School. I just met with the dean yesterday. What can we do together? And then what are we doing individually? And then how do we convince the legislature to make sure that the next train leaving the legislative, the next legislative train, chapter 56, chapter 58, Health Reform Massachusetts, 2006, chapter 305, 288, chapter 224, 2017 proposal bill. How do we make sure the next train leaving the station is a health equity omnibus bill that's just focused on health equity, that may get into all the issues in these reports? You'll see them in the chat. There's the state legislative report. There's the Boston City of Boston report. How do we now make sure that train leaving the station is loaded up with affordability, cost, quality, access, all from a health equity perspective? And last but not least, one of the ideas I had on an Etch-a-Sketch, Neil, about 3 months ago was creating a health equity institute here at the Mass League. Literally, it was like an Etch-a-Sketch, if anybody even knows what an Etch-a-Sketch is, because some people may not even know what that is. So basically, it was an idea. And then Mass General Brigham's, in a grant that they gave us of $15 million, seeded us with $15 million to do some work at SUD, particularly because of the mass and caste and the racial disparities that are playing out with homelessness and substance use disorder along the Blue Hill Ave corridor. And we'll be doing that work with out of health centers to address those issues. And then some of that money will go to behavioral health workforce and supplemental payments to behavioral health providers. But they gave us 1.5 of that 15 million to create this institute. We'll deal with researchers who want to engage our communities. We'll deal with health centers who want to engage researchers. We may do some stuff directly with NIH. We may publish findings that are not through a research entity, but just out of our home. We have the data. We know the patients better than anybody. So maybe we do something around racial anxiety, right? Or maybe we do something around access to oral health and the impact of racial disparities around access to dental care. Or maybe we do something around eye care and whether people are walking around blind because they didn't get the treatment they should have disparately in communities of color. There's so many places, and Neil, the critical point here is, instead of us waiting for somebody to knock on our front door, just say, hey, we want to research you, your communities, your patients. We can say, no, we want to tell you what we want to research. We want the community to drive the research agenda and be partners in that process. That is essentially a walk through time of a whole bunch of issues, but I'll end it on this, policy. Here's where the rubber meets the road. Ultimately, policy is slow process. It is one that you gotta beat the drum. It could take more than one legislative cycle. It could take more than one administration of a mayor or a town manager. But coming with data, coming with real lived experiences and stories matters, because that moves it. What drives Rochelle may not move Elizabeth. Elizabeth if I'm coming to you, could convince you, Elizabeth, to do something, you might be moved by some of these stories about people living with prostate cancer, but that might not move Rochelle. Rochelle may say, no, I want to know about affordability. What is it going to cost me? Am I paying for it? So when we do advocacy, I got to have a whole bag of tricks. I need to have a story. I need to have the data. I need to know the cost, because that's the only way you can get that critical mass of votes and movement and create the political will to create change around these critical issues. That is health policy in Massachusetts. And however many minutes I did.
Michael, thank you so much for a very powerful and very inspiring talk. You've left us with a lot to think about. I'm sure there are lots of questions that folks have. Maybe if I could sort of capture it in some of the things in sort of one key question, given the fact that we do have several of our students who are on the presentation, who are present right now, as well as many of us who are educators or who who are within Northeastern, an educational institution. What can educators and students do to help advance this cause or these causes? There are multiple causes that you have raised.
Yeah, I think part of it is not waiting till you finish, right? Not waiting till you graduate. We know that students matter, right? Faculty matter. So I've had faculty reach out to me, say, Mike, what do you need for the Health Equity Compact? So I had one professor call me from an institution, and I said, you know what I need? I need a slide deck that has all the comprehensive health disparities in one deck. So I can talk about maternal health, I could talk about oral health, I could talk about all of this in one deck. And they said, okay, I'm gonna have my class put the deck together for you. And that's been ongoing for about a month. So when I sit down to make a case for the Massachusetts Health Equity Compact or Health Equity Institute, I got a deck that, what happens, Neil, is we all got pieces. So if you're focused on maternal health, you can speak ad nauseum about the inequities there. If you're an oral health person, you can speak but nobody has the big picture of where all of these health inequities lie and what they look like and what the impacts are. So my answer to your question, Neil, is get in where you fit in. That was a saying when I was a kid in my neighborhood, get in where you fit in, right? Find a place that's doing good work and say, no, we want to be a part of it. And, it's the Northeastern model, right? Mm-hmm. And I say that because I know you intimately. Northeastern model is not just academic and learning it in the classroom, it's experiencing it. Mm-hmm. How do we get in and actually do the work so that we actually walk out with practical experience and awareness about the work? So you're already doing it, but I think there's an opportunity to partner with Morning Star Baptist Church or Boston Medical Center or MGB or Dimmick Community Health Center and say, hey, we want to do a project with you. If it's collecting data, if it's COVID-19 related, how can we work with you to be good community partners as an academic institution, as an aspiring graduate of this institute to support the work you're doing? And I think more and more people like yourself, Neil, are making that kind of call.
Terrific. Well, thank you. And I love the saying, get in where you fit in. I think that really is perfect for us here at Northeastern. Thank you so much for an amazing talk, an inspiring talk. I want to thank my colleagues in the Department of Health Sciences at the Bouvet College of Health Sciences. Also wanted special thanks to Elmer Freeman and the Center for Community Health Education, Research and Service for their co-sponsorship of this event as well. I know we've gone a few minutes over time. We could probably have gone much, much longer over. I know that there are lots of questions and ideas that folks have had, but Michael, you've truly inspired us, and thank you for everything that you do on behalf of all of us across the Commonwealth and around the country.
Well, know that I am an ally and partner of Northeastern and all of you. So anytime that you want to work with community health centers and you want to reach out, know that the answer is going to be yes, Neil. So you'll have me on speed dial.
I will take you up on that for sure.
Thank you all.
Thank you.